attending the Silver Jubilee, OTSI Silver Jubilee online brain teaser quiz competition. This thing came up first from the horse's mouth, that means from the Prashant Bavankule. I was just looking forward to give something to the younger generation who will be stimulated with the ocular trauma work. So this thing came up to me and immediately I accepted and I gave him the charge to do this trauma quiz program. And I think the younger generation will be benefited. Top of that, we will also learn something else, something more. Now, these are the different types of trauma we have already discussed in last 4 Silver Jubilee Symposia. And starting from the domestic violence, pressure cooker injury, lime burn, cracker injuries, agriculture trauma, sports injury, and the industrial trauma. This was a huge thing happened in 1984. More than 65,000 people were affected. So this is such an importance to every one of us, and it's so close to us that if somebody suffers, which is a preventable cause of blindness. So most of the time, 90% of the trauma can be prevented. So with this, I will hand over that platform to Prashant to carry on further.
Thank you, President, sir. Thank you, President, sir, for entrusting this particular responsibility to me, and I hope the younger viewers will develop a keen interest in the ocular trauma prevention and management, and they will be benefited by the end of the quiz and with other programs which OTSI is conducting under your guidance. Now I request Secretary of OTSI, Dr. Mehul Shah, to speak 2 words.
Thank you very much, Prashant. As an initiative, first part, we'll have this quiz, and whole OTSI team has worked hard to collect lot of video, and the whole team has evaluated it thoroughly. And with the end of this event, we are going to present the result of ocular trauma video competition. And so stay tuned with us till the end. In the end of this program, we are going to present the result of ocular trauma competition video competition, and that event will be there on 8th of the November. So all the winners can join us, and all other runners up and all other people also can join us on 8th of the November. Thank you.
Thank you.
Prashant, you carry on, please.
Thank you, Mehul Shah, for a wonderful introduction. I'm sure the participants must be keen to know who are going to be the winners of the video competition. Hold on, viewers. Remember that we are going to also declare the video winners at the end of the concluding ceremony of the quiz. Okay. Now let's move. Share screen. Request all the participants, all the people, guests on the Zoom platform to put off their video as well as audio input off. So this is a signature tune of Brain Teasers. Yes, friends. So, dear friends, good evening. Welcome back to Brain Teasers. Let me introduce you all to the concept of Brain Teasers, at least to the people who are novice to this. Brain Teaser is an edutainment initiative which was introduced last year by Sarakshi Netralaya. In the first season, it was simple online quiz conducted on every Sunday with the weekly and monthly winners. The USP of the quiz was that it had questions based on clinical scenarios predominantly. The response and the feedback to our tiny effort was phenomenal. Buoyed by the success and feedbacks from all of you, Brain Teaser was launched in a new avatar in 2020. Brain Teaser is a live online quiz conducted once a month on a web-based platform on the first Sunday of every month. And it's no longer just a quiz. but much more. To increase your learning and knowledge, we have added new sections like Pearls of the Month and Wisdom from the Heroes in Ophthalmology. Well, friends, 17th October is celebrated across the world as World Trauma Day, as already indicated by our President OTSI, and it was yesterday. My greetings to one and all on World Trauma Day. Look at the coincidence. Our pole-to-pole trauma quiz is a day after World Trauma Day. It's just a sheer coincidence, or it's an astute thinking by our president? The time will tell you. Today is our special day for brain teasers as well. It's our proud privilege to associate with one of the specialty societies of our country, and I'm thankful to all the OTSI executives for this wonderful opportunity. Brain Teasers with OTSI has conceived a mega quiz for all of you, and more than 1.2 lakh rupees are at stake today. Also, the winners will get certificates and, more importantly, opportunity to share the podium or screen with the stalwarts in the world of trauma. Today, we are privileged to have legends in the field of ocular trauma, 3 from abroad and 1 from our own country. They are Dr. Ferenik Kuhn, Dr. Peter, Dr. Prem Subramaniam, and our own Dr. Ashok Grover. And I'm thankful to them for sharing their experience in the form of ophthalmic pearl of trauma in today's quiz. Thank you, Ashok Grover, sir, Ferenik Kuhn, Dr. Peter, and Dr. Prem for giving your valuable time to us. Because of the time zone difference, Dr. Ferenik and Dr. Peter is not able to join meeting, but our sincere gratitude from the bottom of our heart for their contribution to this program. A.K. Grover, sir, and Dr. Prem are here live with us today, and thank you, sirs, for sparing your valuable time with us. We are also privileged to have our special guest, international guest, Dr. Gangadhar Sundar and Dr. Rupesh Agrawal from Singapore as a special invitee. My sincere thanks to President, Secretary, and all executives of OTSI for reposing faith and entrusting me with today's quiz. Thank you, one and all. No mega event is possible without the generous support of Pharma. My heartfelt thanks to Mr. Rahul Nagaraj and team of Cipla for standing rock steady behind us. Today, my co-hosts are 2 young people, Dr. Akshay Nair from Mumbai and Dr. Shilpi Narnavre from Nagpur. Welcome, Akshay. Welcome, Dr. Shilpi. Now, I hand over the screen to Dr. Shilpi Narnavre for explaining you the rules of the game and taking over further. Stop sharing.
Thank you, sir. So, good evening, friends. So, here are the rules for the today's quiz. First, who can participate? Any ophthalmologist who is a novice in ophthalmology, that is a postgraduate to the most seasoned practitioner. Remember, quiz has 5 sections with 5 questions in each section. Every question will have 4 options. Only one amongst the 4 is the correct. So you have to select the correct answer and also click the save button to record your answer. If you are not sure of the correct response, don't be in a hurry to click the save button, because once you click the save button, you cannot change your response. This is what the participants will see on their screen. This is a sample question for your understanding. Identify the character shown in the picture below. Option A, Tom. Option B, Jerry. Option C, Donald. Option D, none of the above. And your time starts now. This timer will play for 20 seconds. You have to record your response only after the timer starts. I repeat, you have to record your response only after the timer starts. If you submit your answer before the timer starts, it will not be recorded. Now, the answer here is B. So first you have to click this B option, and then after that click the save button. So who will win the prize? Naturally, the one who answers correct and importantly answers first, that is fastest finger first. We have 2 categories, one for the people below the age of 40 years and second for above 40 years. So what are the prizes? Every section will have one winner. So it means we have 5 section winners in each category. That's not all. For the whole session of 25 questions, we have 2 mega prizes, one for the runner-up and one for the winner in both the categories. That means in total we have 10 section winners, 2 runner-ups and 2 winners. But remember, you can be section winner only for one section. But don't give up, as you can win the session prize with your consistent performance. If there is a tie for a section, the cumulative performance of all the 5 sections will be considered. But if there is a tie for the session winner, that is runner-up and winner, the dice will decide your fate. In case of any discrepancy, judge's decision will be binding. Now look what is at stake today. Prize money of rupees 6,000 for every section winner. Runner-up gets the prize money of 10,000 and the winner carries away, wow, 15,000 rupees. That means more than 1 lakh rupees is at stake today. It's not only the gifts, you will be invited live for the concluding ceremony where you will share the screen and interact with our today's guests who are who's who in ophthalmology. So winners, be alert. You will be sent a Zoom link as well as you will get a call on your registered mobile number. You will have to join the platform as soon you get the confirmation. Now I invite Dr. Prashant Bavankude to start the game.
Share screen. So friends, are you ready? Geared up for the quiz? So here we start with the section 1. A relatively simple question for you. We begin with a simpler question. This is just now IPL is on and cricket fever is on across the country. But do you remember all these great legends in the field of cricket of yesteryears? Well, I think most of you must have recognized them. All of them have lost one of their eye for various reasons. Only one of them has lost the eye because of on-field injury on the cricket ground. So your options start now. Option A, is it Colin who lost his eye because of cricket injury? Option B, Paul Downton. Option C, Patodi. And option D, our own Ranjit Singh ji. And your time starts now. So who is the cricketer who lost his eye because of on-field cricket ground injury? Yes, it was relatively simple, I believe. And the correct answer is B. It was Paul Downton who lost one of his eye because of the bail which got dislodged and hit his eye during Sunday League match. While Colin and Patodi also lost their eye because of car crash injuries, while Ranjit Singh ji lost his eye during a shooting accident. That is the difference. So all the 4 cricketers had trauma-related loss of eye. Paul Downton because of cricket, Colin and Patodi because of car crash, while Ranjit Singh ji lost his eye during a shooting accident. So it was simple, I believe. So now let's move back to real science. According to OTS classification, that is Ocular Trauma Score classification, Zone 1 in open globe injury involves option A, bulbar conjunctiva, sclera and cornea, option B, anterior segment and pars placata, option C, cornea and limbus, and option D, limbus to 5 mm posterior into sclera. And your time starts now. Yes, time is over, and the correct answer is cornea and limbus. So let me explain you what it means. So zone 1 is the area cornea and limbus. So if you have open globe injury in cornea and limbus, it is called zone 1. Area from limbus to 5 millimeter beyond limbus into the sclera is zone 2, and area beyond that is zone 3. These areas are important to assess that score and understand the importance of the visual prognosis. Now coming to question 3. All are signs of occult scleral rupture except option A, diffuse chemosis and subconjunctival hemorrhage. Option B, flat tire sign on a CT scan. Option C, intraocular pressure most of the times is low. Option D, profound visual loss. Your time starts now. So which is not the sign of occult scleral rupture? What is not seen in occult scleral rupture? What you need to identify. Time is over, and the correct answer is profound visual loss. So let's understand what is this injury. So remember, occult rupture, where does it occur? In a phakic eyes, it is usually under the insertion of extraocular muscle because sclera is weaker in a phakic eye, while in a pseudophakic eye, a relatively weak area is the limbus, or the area through which you have done a cataract surgery. And this is the area where commonest occult ruptures occur, and the diagnostic signs are you get a very boggy conjunctival chemosis with hemorrhage, marked decrease in ocular ductions, deepened antechamber and vitreous hemorrhage. IOP might be reduced but not necessarily, and importance is even in a red eye with no apparent rupture, you need to explore and repair this particular trauma injuries. Now coming to the pain ultimate question in my section, that is section 1. According to BED, OTS score considers the following variables except option A, initial vision at presentation, option B, endophthalmitis, option C, retinal detachment, and option D, corneal edema. And your time starts now. So OTS score does not consider only one of these variables. So which one is it? Which one is the odd man out, which is not considered during OTS scoring? And the time stops here. And according to Bates, OTS score does not consider corneal edema. The rest parameters are considered. So what is OTS? OTS was developed to prognosticate the final functional outcome in a trauma case. If you have a better score, better is the visual prognosis. And these are the variables which are used, that is initial visual acuity, ruptures, endophthalmitis, perforating injury, RD, and REPD. Corneal edema is not considered during scoring. Now moving to the last question of my section, that is question 5. Which of the following are not among the 7 rings in blunt trauma? So there are 7 classical rings described in literature. Option A, separation of ciliary body from the scleral spur, that is cyclodialysis. Option B, trabecular meshwork, that is trabecular meshwork tear. Option C, anterior chamber hyphema. And option D, zonular tear with possible lens subluxation. And your time starts now. So one of them is not considered if taken into account in the 7 rings in blunt trauma. Well, the correct answer is option C, that is anterior chamber hyphema. So let's understand a bit about 7 rings of blunt trauma. So what are the 7 rings for the postgraduates and the residents over there? Sphincter tear, iridodialysis, cyclodialysis, angle recession, trabecular meshwork tear, zonular tears, and retinal dialysis. These are the 7 rings of blunt trauma which you might be asked during your postgraduate or fellowship exam. So do remember that. So that is the way. So here I am at the end of section 1. Now, till the back office computes the result of the section winner, we have a break. During this break, we are going to have one pearl, trauma pearl by Dr. Ashok Grover. Let me introduce to you to Dr. Ashok Grover. He's a Padma Shri recipient and he is a president, South Asia Association of Oculoplastic, Reconstructive and Oculofacial Aesthetic Surgery, chairman, subspecialty education, ICO, counselor, APOA. He has been past president of APSO, PRS, OPAI, and All India Ophthalmological Societies. He has received numerous prestigious awards and international and national orations. Editorial board member of several national and international journals, authored, edited 5 books, and written over 50 chapters in textbooks, and has 60 publications to his credit. So here we are with this video, his Pearl of the Month.
Good evening. Today I speak to you on some pearls for the management of eyelid, canalicular, and orbital trauma. Eyelid injuries are some of the commonest injuries that present to a general ophthalmologist. The objectives of eyelid repair are to re-establish anatomy, physiology, and restore aesthetics. The lacerations require a simple reapposition of the wounds, when simple but complex ones may require more complex repair with flaps or even grafts. Marginal repair is the most critical technique. Or silk suture is preferred. 3 marginal sutures are placed as vertical mattress sutures. The first one is placed at or just behind the line. The second one is placed closer to the posterior margin. And the third one close to the lash. These sutures start 3 millimeters from the cut edge, go to the 3 millimeter depth, and come back 1 millimeter from the edge, 1 millimeter depth, and 1 millimeter back. These oppose the wound, causing a little pouting. All these sutures are tied anteriorly with the most anterior suture so that they don't irritate the globe. The tarsus is then opposed with a 6-0 vicryl suture, which is placed partial thickness. Skin is then opposed with sutures of nylon. These injuries heal very well, leaving behind virtually no scars. If there is fat prolapse, levator injury must be suspected and sent to an oculoplastic surgeon. Medial canthal injuries that are deep are often associated with canalicular injuries and of the posterior crus of the medial canthal tendon, which can lead to permanent telecanthus. These also require a referral to an oculoplastic surgeon. Same is true for the lateral canthal injuries, where canthal deformities can result from the dissociation of the lateral tarsus from the lateral canthus. Delayed or improper repairs often lead to traumatic deformities of various kinds. These require technically demanding skills and techniques and are best handled by an oculoplastic surgeon, often working with other teams. Canalicular injuries require an early repair, preferably within 24 to 48 hours. And therefore, it is ideal that they are immediately repaired if the surgeon is confident. If not, they should be referred to an oculoplastic surgeon. It is important to identify the medial cut end, oppose the ends, and do a stenting, which is retained for the required period of time. Medial cut end can best be diagnosed by good illumination and high magnification of the microscope. In difficult cases, an air injection from the opposite punctum with a little fluid at the medial canthus allows the diagnosis of the medial cut end. It is then stented with a silicone material, best material being a mini Noka stent. The surgical technique involves opening up of the punctum to allow stent to go in. The stent is then placed through the lateral cut end, through the medial cut end, till it reaches a hard stop. It is then the next step to close the pericanalicular suture, the areas by a 80 vital suture. These sutures are placed all around, and then a marginal repair is carried out. The stent is retained either as a self-retaining mini Monaka stent, or it must be fixated well. Orbital fractures are complex. At times, they involve multiple other bones and the various walls of the orbital wall. A comprehensive multidisciplinary approach is often needed, and oculoplastic surgeon is often a team member of these teams. It is therefore important that these are referred to the appropriate. An example is this patient with bilateral traumatic telecanthus and lateral traumatic NLDO, operated with a neurosurgeon with transnasal wiring with bone grafting. The results can be extremely gratifying when done in teamwork. Orbital floor fractures are diagnosed by the presence of ecchymosis, infraorbital hypoesthesia, restriction of upward and sometimes downward motility, presence of enophthalmos, and downward displacement of the eyeball. They're best diagnosed by CT scans, including coronal sagittal cuts and 3D reformatting. The video films showing the anterior to the posterior extent, both in coronal and sagittal cuts, are valuable in assessing the extent of the fracture. These are managed by intervention where indicated, and the appropriate surgical approach must be chosen. Wide-eyed fractures, which have incarceration of the muscle with a non-resolving oculocardiac reflex, constitute an emergency repair. All other cases, like this one, with a floor fracture and incarceration of the contents in a child, is an emergency because of the risk of oculocardiac reflex and necrosis of the muscle due to incarceration. All other cases can be repaired as subacute repair. The conjunctival approach incision is often the first choice. The periosteum is incised, the orbital floor is exposed, and the area of fracture with incarceration of contents is identified. These are then lifted with the help of hand-over-hand maneuvers till the floor is free and all the extents of the wall can be seen on. The force duction test must become free at the end of the surgery. The extent of the fracture is now clearly seen here, including the antrum, which can be seen in the center of the fracture. The force duction test is now negative. This is an example of a patient with a floor and a medial wall fracture. This has been repaired with a titanium plate, which is often good for extensive fractures, and it covers the floor well with establishment of the contour. Computer modeling and intraoperative navigation are also being used more often in maxillofacial and orbital fracture repair now. This is an example of a gross restriction of upward motility following an orbital floor fracture repaired. This is the CT scan showing the incarceration of contents. After the repair, the ocular position has been improved and the upward motility restored. Management of eyelid trauma is critical. It can provide excellent results and can transform lives. Thank you very much for your attention.
Thank you, sir. And meanwhile, we are back with our winners. So, the section 1 winner under the age of 40 years is Mr. Dr. Muthukrishnan from Chennai, and Dr. Kamal Pevria in the section 1 above the age of 40 years. Congratulations, Dr. Kamal and Dr. Muthukrishnan. You continue playing the thing, but remember, you will be getting a Zoom link at the end of at the conclusion of all 5 sections. Do remember to join us and share the screen. Congratulations once again. Now, here is my responsibility to introduce this young guy. This young guy is he has done his residency, that is Dr. Akshay Nair from Shankar Nethralaya, in that fellowship in oculoplasty from LV Prasad Eye Hospital. And at his tender age, he has only 90 plus peer-reviewed index publications and 15 plus textbook chapters. What more do I need to introduce this young man? Over to you, Akshay, for further proceedings.
Thank you so much, sir, for that kind introduction. I will now share my screen and guide you through the second section of this wonderful quiz, that is brain teasers. The rules remain the same, so stay attentive, stay alert, and stay on the on your mouse or on your touch screen to answer as soon as you can. The first question of your section 2 is this. This is a CT scan of a 35-year-old male who underwent functional endoscopic sinus surgery for sinusitis. After surgery, he developed diplopia. Looking at the scan, what do you think is the most likely pathology? Intraoperative third nerve palsy, traumatic optic neuropathy, iatrogenic medial rectus damage, or transient myopathy following general anesthesia? Your time starts now. Right. The correct answer here was iatrogenic medial rectus damage. Many times our ENT colleagues during debulking or any maneuver in the ethmoidal sinus can actually damage the medial wall, and the medial rectus is one of the first structures that prolapses when the periorbita is incised, and therefore they can be damaged. Diagnostic sign is that the kink in the muscle seen on the CT scan, initially it is conservatively managed, and later on our squint colleagues can go in and help them. The next question is this. Look at the CT scan carefully. This is a scan of a patient who had a road traffic accident and suffered facial trauma. What word best describes this type of injury? Is it A, a palm tree injury? Is it B, a crab claw injury? Is it C, a tripod injury? Or is it D, a trapdoor injury? Your time starts now. It's a visual clue. Look at the image and the answer should come to you. This is a 3D reconstruction. Time's up, and the answer here is a tripod. A tripod injury, basically, as you can see in the CT scan, is where the bone is broken at 3 places. These are 3 fractures involving the zygomatic arch, the lateral orbital wall, and the inferior orbital wall. Therefore, the bony piece that is free floating is a tripod shaped bony fragment of the zygomatic maxillary complex. Our next question is this. Regarding globe perforation during local anesthesia, which is not considered a risk factor? Is it A, proptosis? Is it B, a previous scleral buckling procedure done? Is it C, a posterior staphyloma? Or is it D, bevel of the needle turned away from the globe? Read carefully. Your time starts now. Time is up. The correct answer is that the bevel of the needle should be turned away from the globe. It is not considered to be a risk factor. The needle should not only be away from the globe, but it should also be passed straight back below the eye for 15 millimeters to make sure that no portion of the globe is damaged. Proptosis, previous scleral buckling, and posterior staphyloma are all associated with anterior displacement of the globe or axial elongation, and therefore these eyes are more susceptible to inadvertent perforations. Our next question is this. Look at this instrument carefully. There are two ends to it and they are shaped in a particular way. Looking at that, what is this most commonly used for? Is it A, locating the cut end of a lacerated canaliculus? Is it B, exploring and retrieving a lost rectus muscle? Is it C, expressing the lens material out of the eye in case of a cataract? Or D, is it used as in a trabeculotomy? Your time starts now. Both ends are identical of the instrument. They have a very typical curve. The right answer is, as you can see from the shape of that curve, it is used to locate the cut end of a lacerated canaliculus because that resembles the tail of a pig, and that's why it's a pigtail probe. In canalicular lacerations, a pigtail probe is introduced through the upper punctum or the intact punctum and rotated through the intact canaliculus and the common canaliculus, and the shape of the instrument is such that it should come out through the lower canaliculus cut end, through then where it is threaded with a needle or a suture, and then you can have reconstruct the entire cut canaliculus. This is the last question of this round. A patient with panfacial trauma presented with reduced vision unilaterally. This is the CT scan image, an axial slice. There is an arrow pointing to something. What should the treatment of this be? A, optic nerve fenestration. B, optic canal decompression. C, megadose IV steroids. Or D, low dose oral steroids. And your time starts now. Time is up. This was one of the more confusing questions. The answer here is an optic nerve fenestration. What you see on the CT scan is a thickened optic nerve, which is indicating an intra-sheath hematoma. Hematoma or blood collection within the optic nerve sheath. And typically, there is a history of trauma, reduced vision, and on imaging, there is an appearance of a thickened nerve. Here, a fenestration would relieve the pressure of the blood within the optic nerve sheath. However, it is important to know that an MRI is more sensitive in picking up an intra-sheath hematoma. With that, we now come to the end of this round. And as we have our backend team working to get our results, I have the honor of introducing our second guest who will be giving us his pearls on ocular trauma. It is my honor to introduce Professor Peter McCluskey. He is the professor of clinical ophthalmology and eye health and director of Safe Sight Institute in the Faculty of Medicine and Health in Sydney, University of Sydney. He is an internationally recognized expert in uveitis and inflammatory eye diseases. He heads the largest tertiary eye care referral uveitis service across Australia, with over 250 papers published and multiple textbooks and mobile applications to his credit. Dr. Peter McCluskey would be talking to us on something that is very close to his heart and something that he's been researched, something that he's researched a lot in depth. Due to the time difference and the time zone, we have with us a pre-recorded message from him.
Hello, everyone. I've been asked as a speaker at the recent Asia Pacific Ocular Trauma Society meeting to give you a distilled take-home message from my talk on sympathetic ophthalmia. Sympathetic ophthalmia was first recognized by Hippocrates, and it was also recognized by Archimedes, who deliberately used to infect horse eyes when they were badly injured to try and prevent sympathetic ophthalmia by destroying the injured eye from infection. Probably the most famous person who's gone blind from sympathetic ophthalmia is Louis Braille. Mackenzie was one of the first people in the modern era to describe sympathetic ophthalmia, and the modern sort of clinical features were refined and described by Fuchs early last century. The sine qua non for sympathetic ophthalmia is a history of eye trauma, be that accidental trauma or injury or surgical trauma from vitreoretinal surgery predominantly. We know that sympathetic ophthalmia is a bilateral granulomatous panuveitis. There's an exciting and a sympathizing eye. And interestingly, the incidence of this disease has dramatically decreased over the last 250 years. Back in the American Civil War, the incidence of sympathetic ophthalmia was about 1 in 250. In World War I, it was around 1 in 300. By World War II, it was down to 1 in 2000. And in conflicts since that time, essentially there have been no recorded cases of sympathetic ophthalmia. Indeed, we know that it's now quite a rare disease. The surveillance study done 20 years ago in the UK showed an extremely low incidence of 0.03 per 100,000 individuals. And the commonest cause in the surveillance series was vitreoretinal surgery. In a large series from South Africa, again, sympathetic ophthalmia was extremely uncommon. And interestingly, they found no cases in eyes where the traumatized eye, in patients rather, where the traumatized eye had been removed. Other series from other parts of the world have confirmed that it's a rare disease and that today, arguably, the commonest cause is multiple vitreoretinal surgeries. We know sympathetic ophthalmia is a bad disease. This excellent series by Jennifer Thorne and colleagues showed that a quarter of the patients presented with poor vision in the sympathizing eye, and that it was quite common to get vision loss during follow-up. In round numbers, half the patients had significant structural complications at the time of their presentation, and during follow-up, complications were very frequent. Cataract, optic neuropathy, and exudative retinal detachment were the commonest complications that were seen. And an exudative retinal detachment was the risk factor for a poor visual outcome. That said, with modern medical therapy, 60% of the patients had a really good visual outcome of better than 6/12, and 3/4 of the patients had a good visual outcome of vision better than 660. So where are we now? We believe that removal of the injured eye does not prevent sympathetic ophthalmia, and that there is no protective time window. The very low incidence of sympathetic ophthalmia that we see now is due to expert surgical repair of injured eyes, good surgical decision-making to remove eyes that are unsalvageable, and modern antibiotic therapy for infection and combination immunosuppressive therapy to control inflammation. We do know, however, that surgery in eyes that have had a past history of trauma can trigger the onset of sympathetic ophthalmia. I've already mentioned that multiple vitreoretinal surgical procedures are the commonest cause of sympathetic ophthalmia these days. But in patients with trauma, we decide whether or not to keep the eye or to remove it on a patient-by-patient basis based on surgical factors. And the commonest method of removing an irretrievably damaged eye is by evisceration. And importantly, with combination modern immunosuppressive therapy, the majority of patients do well with sympathetic ophthalmia. So is sympathetic ophthalmia still relevant in 2020? Yes, it is. Although it's a rare disease, it's a severe threat to vision. Although the exact pathogenesis remains unclear, it's probably an autoimmune disease. The initial innate immune response following trauma begins within minutes to hours, and this then drives a very strong adaptive T-cell driven immune response which persists in patients who get sympathetic ophthalmia. And modern immunology theory says that there is no protective window that will prevent sympathetic ophthalmia, and almost certainly there are other factors that make patients prone to developing sympathetic ophthalmia. And as I mentioned earlier, evisceration or enucleation when needed and aggressive effective treatment for sympathetic ophthalmia gives a good visual outcome in most patients. Hello, everyone.
All right. So with that, we have with us the names of the winners of section 2. Under 40, our winner is Dr. P.V. Jayashree from Bangalore. And in the above 40, our winner is Dr. Muhammad Irfan Rawal from Mumbai. And both of these winners will be joining us at the end of the session. And y'all can still, win the final quiz. So stay tuned. We'll be getting in touch with you soon. So congratulations to all of you. In the meanwhile, before we move ahead, I'd like to dwell upon Professor McCluskey's talk for a couple of minutes. Dr. Rupesh, if you could unmute yourself. Thank you so much for joining us. Thanks. You can see you now as well. So,
thank you,
we keep hearing about the importance of the principles that help us in preventing sympathetic. But, just to address one of the questions he asked, where are we ourselves? Are we still seeing episodes or incidences of sympathetic ophthalmia? And if not, what do you think we are doing differently now that we are not seeing it so much?
Akshay, that's a very important question, and I am glad that you asked in this context of OTSI. And thanks to OTSI for bringing up such an important topic, which is definitely close to my heart and Dr. Natarajan and Dr. Mukherjee and everyone. So one of the very important issues which we are trying to address here is sympathetic ophthalmia relevant today? So to answer Akshay's question, which is very relevant, is the incidence, and you can call it as a prevalence of sympathetic ophthalmia, has come down quite significantly. So I don't remember seeing any case of sympathetic ophthalmia for past few years, at least in my practice. I think the same thing has been shared by Professor McCluskey as well and Dr. Biswas in Chennai. Not that many cases are coming. One of the reasons of probably lesser sympathetic ophthalmia is better management of ocular trauma, and that is where we have to go back into the basics of primary repair. And sorry, I've got a bit of background noise here. Sorry for that. But when we go into the basics of ocular trauma repair, the more clean repair and more thorough repair and more timely repair is probably preventing us from getting sympathetic ophthalmia. Now, when I say clean repair, that means you're not messing up with the iris tissue, cleaning up the iris tissue. The teaching has been there. And I think that's something which is helping. And also, whenever people see any signs of inflammation and all, they've been giving treatment. Yeah.
Right.
Can I add a point?
Absolutely,
yeah,
sir, please.
Yeah, no, and continuation of Rupesh, what he mentioned, and I was in part with Gangadhar Sundar and Dr. Peter McCluskey in WC. He mentioned that now, post-VR surgery, we are seeing more sympathetic ophthalmia than trauma. And I think I agree with that. I saw post-trauma several years back. And now I think some time back, I've seen post-vitrectomy in a young 20-year-old girl after multiple surgeries. I identified, because I remember I wanted every resident to know this. What is that? Parsons has a beautiful definition for sympathetic ophthalmia. Maybe we should have it in the quiz as what is the one simple sign is difficulty in reading in a young individual, and particularly 18 or 20, when you have an injury in one eye or a surgery in one eye and you suddenly have a difficulty in reading because of the accommodation which happens in sympathetic ophthalmia. I think we treated as he said, autoimmune disease, and I referred to Dr. Bishwa at that time. So post-surgery, particularly vitreoretinal surgery, because it's involving the pars plana, and I think one of the theory is retinal S antigen released when the uveal tissue is incarcerated in the wound, and that's why Dr. Jovanovic recommended an invagination of the tissues like this, so that the scleral edges are not having the uveal tissue. So I think when you do a wound repair, we recommend, and I think Rupesh also agrees to that, an expert, if is available, should do the wound repair. Nothing against the young doctors, but I think the idea is already the anatomy is disturbed, the planes are disturbed. So I think if you do, and I still do, if I'm on duty, or rather I'm available, and if a young consultant like Akshay allows me, I will do the surgery in Aditya. Otherwise, I don't get a chance to do wound repair now.
Right, sir.
Yeah, one thing.
All right.
Already Rupesh and meticulous management of the case. About after the introduction of the corticosteroid, the incidence has started coming down, and now with the availability of all armamentarium in our hand, microscopic surgery, viscoelastic substances, good suture technique, all these factors play an important role in the management of such type of trauma.
Very quickly, sir, I will add one point, is people to be a bit careful about using corticosteroid in the form of systemic, and only when they are quite certain that they are not dealing with infection, they can go ahead and use oral steroid in case if they want to make sure that the infection has been ruled out. Because sometimes infection can also present with inflammation, particularly endophthalmitis. So they need to kind of be careful and differentiate between endophthalmitis versus the inflammation. And then they can go ahead and start the steroids. Thank you.
Thank you so much. That was a wonderful, spontaneous discussion that was very insightful. Thank you. We congratulate our winners again. And I have the pleasant task of introducing my co-host, Dr. Shilpi Narnavre, who has been the backbone along with Dr. Prashant Bavankule in in making this presentation and compiling the questions. She is a well-published author with 19 international and national publications, and she serves as a reviewer for many prominent journals, including the European Journal of Ophthalmology and Therapeutic Advances in Ophthalmology. Award-winning videos at OTSI and the APOTS meeting at 2019 and 2018, where she won the similar award at the World Congress of Ocular Trauma. She's also been a past editor of magazine of the Ophthalmological Society of Nagpur. Primarily, she is a vitreoretinal surgeon with a focus on ROP, and she works at Sarakshi Netralaya. And can I please invite her to take over and proceed with the next round? Dr. Shilpi, please.
Yes, sir. Thank you, sir, for your kind introduction. So I'll start sharing my screen. So 2 sections are over. And here is the first question of section 3. After blunt trauma, AC wash for hyphema is indicated in the following situations except option A, corneal blood staining, option B, IOP elevation not responding to medical treatment, option C, severe inflammation in anterior chamber, option D, IOP 30 millimeters of mercury in sickle cell patients. And your time starts now. I'm sorry. So time is up. So the answer here is severe inflammation in anterior chamber. In this case, AC wash is not indicated. So coming to the principles of managing a case of hyphema is to facilitate the quick absorption of blood with avoidance of recurrences and prevention of complications. Conservative management in the form of proper position, avoiding strenuous activities and cycloplegics, while the surgical management is indicated in the form of AC paracentesis with irrigation and aspiration, and the list where we need to do the surgical intervention is listed here. So coming to the second question of the section 3, causes of early onset glaucoma after blunt trauma are all except option A, trabeculomeshwak inflammation, option B, hyphema, option C, ghost cell glaucoma, and option D, none of the above. And your time starts now. So time is over. And the correct answer for this question is ghost cell glaucoma. Yes, ghost cell glaucoma causes late onset glaucoma, while trabeculomeshwak inflammation and hyphema are the causes of early onset glaucoma. Ghost cell glaucoma develops because of the hemolyzed RBCs, but remember, presence of ghost cells does not always lead to the development of ghost cell glaucoma. So now here is the third question of this section for you. Oh, I think this question a few minutes ago, Dr. Grover sir had already explained about this fracture. True about white-eyed fracture is option A, usually seen in people older than 40 years of age. Option B, urgent treatment is needed in these cases. Option C, roof of the orbit is most commonly involved. And option D, all of the above. And your time starts now. So time is over. And the correct answer here is, I think everyone would have guessed. Yes, it is urgent treatment is needed in these cases. As the name suggests, you can see hardly any injury marks on or near the orbit. It is usually seen in patients less than 18 years of age, and orbital floor is the most commonly involved area. Acute incarceration of herniated tissue in a trapdoor effect is the main cause. Patients present with acute nausea, vomiting, and headache, urgent repair is needed to avoid permanent neuromuscular damage. So now the fourth question of this section. Following principles for corneoscleral wound repair are true except option A, sutures are passed through 90% corneal depth and burp in the cornea. Option B, entry and exit points are equidistant from the wound edge and are perpendicular to the wound. Option C, you have to take the longer sutures near the limbus and shorter towards the central cornea. Option D, you have to start from the posterior and then go anterior for the scleral suturing. And your time starts now. So time over. And the correct answer here is start from posterior to anterior for scleral suturing. This is the wrong option. Basically, you should not start from posterior. You have to start from anterior to posterior while doing the scleral suturing. So these are the landmarks in corneal while repairing a corneal laceration. You have to first take the suture at the limbus, you have to take care of the sharp angles or the stellate edges so that you can take a hold on the tissue and then you can repair the rest of the wound. In corneal tear repair, you have to take the sutures which should be 75 to 90% deep, and entry and exit should be 1 millimeter away from the wound edge. While in cases of scleral tear repair, you have to close the close as you go manner. So coming to the last question of this section, which of the following is not correctly matched? Option A, chalcosis. Option B, siderosis. Option C, argyrosis. And option D, traumatic cataract. And your time starts now. So time up. I think this is a very easy question. And the answer here is yes. The wrong option is argyrosis. So this is a chart which shows you which type of cataract you will get in which cases. In cases of copper foreign body, you will typically get a sunflower cataract, while in cases of iron foreign body, it is a typical rusty appearance. And chronic high doses of silver consumption leads to deposition in the basement membrane. So this is the end of our section 3. And while our backend team is computing the results, it is my proud privilege to introduce our third guest, Professor Ferenc Kuhn. After completing his graduation from University of Pécs, he was conferred board certificate in ophthalmology in 1981 and PhD degree in 1999. He was associate professor and deputy chairman at University of Pécs till 1989. Later, he was appointed as associate clinical professor at University of Alabama at Birmingham in 1996 and professor of ophthalmology at University of Pécs in 2003. He was elected as executive vice president of International Society of Ocular Trauma in 2000 and has been its president since January 2012. In spite of being a busy VR surgeon, he has main interest in epidemiology and treatment of ocular trauma. He played a key role in development of United States Eye Injury Registry. He has 216 scientific articles and book chapters in his name. He is a reviewer of several major journals. He has given more than 1,500 scientific talks in more than 51 countries. He has performed live surgeries in 17 countries. We are proud to have Pearl from Professor Kuhn, who is the principal author of Birmingham Eye Trauma Terminology and was principal investigator for development of ocular trauma score. Because of the time zone difference, he is not in person with us. We'll miss you, sir. OTSI and Brain Teasers is sincerely indebted to your contribution.
This is a case where the injury occurred a few weeks earlier. The patient was not referred for surgery. You can see that we are into the last stages of the vitrectomy process. You can see the vitreous, which had a huge hemorrhage. The reason why surgery was not done was because, again, the ophthalmologist did not do vitrectomy himself and did not refer the patient earlier. Part of the vitrectomy process is always detaching the posterior hyaloid, which is clearly visible on the video. In this case, he is incarcerated into the impact site, which is just inferior on the video, superior obviously to the disc. You can see some more fresh hemorrhage, but mostly the vitreous hemorrhage is white. You can see a white ring around the foreign body impact site, which is just a reaction to the impact. With time, this would turn into pigmented ring. So fast forward, you can see the vitreous being cut from around the impact site. What will not be shown on the video is the end of the surgery. Once the foreign body is removed, the vitreous removal will be completed, including a check on the posterior hyaloid using triamcinolone to make sure that nothing is left behind. I surround the impact site with endothermy lesions. First, this is to prevent bleeding. Second, it is also a form of chorioretinectomy to make sure that no PVR will occur after surgery and no retinal folds will develop. So I'm using here various sharp instruments such as scissors at the moment to cut the capsule, the fibrous capsule, which by now surrounds and holds very firmly the foreign body. Never try to use magnet or any other instrument to simply do the removal because it would tear the retina. So after the size of the foreign body is judged based on comparing it three-dimensionally to the intraocular instruments, a scleral incision is made, and then the choroid, which is of course more elastic, is cut at both ends with scissors. And now intraocular magnet, this is my own version, is used to pick up the foreign body. Some of the capsule, as you can see, is still attached to it. One must not be in a hurry to extract the foreign body. As you will see, it has to be done very slowly. The biome now swung out. You can see I removed the light pipe and I use the same hand with the forceps to elongate the wound because you don't want to lose the foreign body at the exit site. Now it is extracted and shown. Again, this is why you have to use judgment in predicting the size of the foreign.
So, thank you, sir. There are a few questions from the viewers. In absence of Professor Kuhn, I request Dr. Natarajan, sir, to answer the queries. Natarajan, sir?
Dr. Shilpi, you can start the questions, maybe.
Yes.
Yes, Shilpi.
Yes, sir. Sir, the first question is, when should we operate a case of intraocular foreign body? And what is your take on doing phacoemulsification even in a clear lens for removal of such large foreign bodies through limbal route, as creating a large scleral wound in such large bodies can lead to dialysis or retinal detachment?
Yeah, I think it's an excellent point. And I think you have to be, I always say that to avoid complication, you have to anticipate. So that's why you have to have a game plan while doing surgery. So we should follow the logarithm as Steve Charles given for vitreous surgery general. And Ferenc Kuhn in his book also mentioned, because it's like playing a soccer. You don't know the opponent's team, particularly in trauma. It is like always a temple of surprise, like what earlier the abdominal surgeons used to say. So I think when in intraocular foreign body, better to operate as early as possible. So it is doing all the investigations. And in case there's a sign of any early sign of inflammation or infection like endophthalmitis, it's a true emergency. But if it is not, I think you can take your time, at least a day, and then plan the surgery. So that one of the things, you need the regular operation theater, you need the regular instrumentation, you need regular assistants who can assist you know where are the instruments kept. For example, the large size foreign body, where are the forceps kept? And the other question is, when you're going to remove a large foreign body through pars plana, there's a definitely high risk of retinal dialysis. So however vitreous based excision you do, Sometimes we also place a encircling band to prevent that. But if you can do a clear lens extraction through the making a posterior capsulotomy and then removing the large foreign body through the limbal incision, and then you can suture it and put an intraocular lens at the same time and complete the vitrectomy, removal of the foreign body and intraocular lens. I think you're doing or do a secondary implant. Nowadays, they also do the iris claw lens on the posterior surface of the iris, which is, I think, an excellent technique to do.
Okay. Thank you, sir. So now it's time to declare the Section 3 winners for less than 40 years of age.
Dr. Silpi, can I make a comment about the question which you are, sorry to interrupt you, but I thought that's a very important point which you mentioned about posterior scleral laceration. So we had a very interesting case where people opened the scleral wound, then they said anterior portion, they explored the scleral wound and then they never repaired. And then the comment given was because the posterior extent of the wound cannot be reached. So that's a kind of a bit tricky thing, and I think that's people think that if they cannot reach posterior end of the scleral wound, they should not repair. So my suggestion here to all the young doctors who are on this forum, you start repairing from the anterior scleral laceration. Go as far as posterior you can go. If you cannot go posterior, close it and make sure that you make a comment in your intraoperative notes, and so that a future surgeon or retina surgeon will know that you put whatever 5, 6, 7 interrupted suture. And where did you stop? If the wound is going beyond muscle rectus insertion, if you have talent to remove take off the muscle and stitch it back, probably try and do that. But if you cannot, then please make a comment about it, so that when a retina surgeon goes inside, he will not get a surprise. Otherwise, it will all leak from inside. So therefore, I thought that will be a good point if someone is doing a scleral laceration repair. Sorry to interrupt you.
No, it's okay. Yes, this was a very nice point, sir. So time to declare the Section 3 winners for less than 40 years of age. Dr. Anu Zoon from Delhi, and for more than 40 years of age, Dr. Gaurav Majumdar from Kolkata. So over to Akshay sir for Section 4.
Thank you so much. Right. So now we move on to Section 4, and the rules as always remain the same with no change. So here's the first question in Section 4. The most common site or location for optic nerve injury in cases of traumatic optic neuropathy is A, the intraocular portion of the optic nerve, B, the intracanalicular portion of the optic nerve, C, the intracranial portion, or D, the intraorbital portion. Your time starts now. And the correct answer is the intracanalicular portion of the optic nerve. The reason behind this, of course, is that during injury to the orbit, the deformity stress is transmitted to the skull from the blunt trauma forces, and it gets focused and concentrated in the region of the optic canal. Within that, it is the intracanalicular segment, because around this, you have the dural sheath, which is adherent to the periosteum at this specific location. As a result, all the damage is focused there, and that results in traumatic optic neuropathy. Our next question in this section is this. Observe this image and tell us that the only true statement about this figure shown are all except that in this case, vision loss is profound, that the damage of the nerve is seen at the level of lamina cribrosa, that a CT scan is helpful in confirming the diagnosis, or D, immediate surgical intervention is indicated. Which the following are true statements except. Your time starts now. The right answer in this is, or rather the wrong answer here would be, immediate surgical intervention is indicated. This, as you can see and you know, is optic nerve avulsion, and the vision in most cases is reduced to no perception of light. Immediately after suffering or traumatic optic nerve avulsion, when you see the fundus, you would see that the disc is obscured by overlying vitreous hemorrhage. Later on, you will see a scleral canal, which is completely devoid of the disc and the optic nerve. CT scan or ultrasound can be useful in confirming a diagnosis or even an MRI. This is irreversible, and therefore no treatment is useful or advised. The pathophysiology behind this is that there is a rapid increase in intraocular pressure, which adds to the forces that causes the nerve to disinsert. There is also a simultaneous rise in the intraorbital pressure, which causes the optic nerve to get stretched in both directions. As a result, that also contributes to the avulsion from the scleral insertion into the globe. Add to this the rotational forces and the displacement of the globe within the orbit, and there is an immediate abrupt disruption at the laminar region of the optic disc, and the nerve comes apart from the globe. With that, we come to the third question in this section, which is an image shown here. Now, this is a young patient who was brought to the hospital in a stretcher. He had suffered facial and head trauma. The attending noted that the cloth under the head showed a double ring sign. Now, what does this indicate? Attached is also the CT scan, the axial slice. This indicates a subdural hematoma or an optic nerve avulsion or a CSF leak or a globe rupture. And your time starts now. Right. The correct answer in this case is that this double ring indicates a CSF or cerebrospinal fluid leak. The mechanism behind the occurrence of a double ring sign is based on the principle that the blood and the CSF disseminate across the cloth at different rates due to different fluid densities, blood being more denser than CSF. And therefore, there are two rings created, one of the blood and the second by the CSF, which has dispersed quicker and faster. So you see two rings. This can also be used intraoperatively when you're operating within the orbit or the nose, where you come across a fluid which you're suspicious about and is mixed with blood. You dab a paper, some amount of the fluid, and or take a filter paper and drop it in it, open up the filter paper, allow it to dry, and if you see two rings, the fluid you're dealing with is the CSF. Our next question for MCQ 19, the fourth of this section, is which of the following do not appear radio opaque on a CT scan? Is it A, glass, B, iron, C, porous polyethylene, or D, wood? And your time starts now. The correct answer for this question is wood. Now, intraorbital wood may be missed in CT scans in the acute stage, also because as time goes on, wood tends to imbibe a little bit of fluid from the extravasation around it. And initially, because of the apparent air attenuation of the foreign body and the lack of contrast with the surrounding intraorbital fat, it can be missed. However, later on, after a certain amount of delay, wood can be visualized in CT scans with a trained eye. Our last question for this round is, this is an axial slice of a CT image. What is the arrow pointing to? There's a yellow arrow. Is it pointing to a PMMA orbital implant? Or B, an endophthalmitic eye? C, silicone oil in the eye? Or D, gas tamponade following a surgery? Your time starts now. little tricky one here. The correct answer, of course, is it is silicone oil. Silicone oil tends to have a high amount of density, that is the Hounsfield value, or the units is very high, it's 100. Blood is less than 90 Hounsfield units. Values, of course, vary depending on the CT scan parameters, but compared to PMMA or purulent material that you would see in endophthalmitis, silicone oil has a very high Hounsfield unit value. And with that, we come to the end of this round, and I now have the honor and the privilege of introducing our next luminary, who will be telling us and giving us some tips about traumatic optic neuropathy. Amongst the many hats that he wears after is including neuro-ophthalmology, a neurologist, a neurosurgeon. His specialties are across neuro-CNS cancer, skull-based tumors, ophthalmic oncology, pediatric ophthalmology, and adult strabismus, and neurosurgery. He is also an avid French horn player and takes active interest in skiing and riding. So while the academic interests of his are well known, Dr. Prem Subramaniam is equally interesting with his extracurricular interests. Can I have Dr. Prem share his screen and share his video?
Good morning. I can bring this up here. Give me one moment. Thank you very much.
Great. And good to see you that early in the morning for you there.
Yeah, we are really thankful to you, Dr. Prem, for all this.
So,
thanks, Prem. Oh, good to see you.
Dr. Prem, your voice is not audible.
Oh, one moment. It's playing a recording here, so let me set this. I can just repeat what it's saying. So, traumatic optic neuropathy is, as was already mentioned by Dr. Akshay, typically from a blunt trauma to the forehead, typically transmitted along the optic canal and resulting either in fracture to the optic canal or more commonly just the transfer of injury to the canal. And so this is an example here of a patient who had both fracture as well as traumatic optic neuropathy on the left side, where you can appreciate that there is a canal fracture impinging upon the optic nerve, in addition to fractures along the lateral orbital wall. And so an afferent pupillary defect, of course, would be expected to be seen in a patient like this. Remember, for the trainees there, that if this patient had sustained bilateral trauma, it is possible that they would actually have a lack of a relative afferent pupillary defect because both optic nerves are injured. So don't be fooled by that in situations where the vision is reduced bilaterally, but you suspect that there still may be a traumatic optic neuropathy, and the arrow here is pointing to that optic canal fracture that I was talking about before. A fracture is not necessary in order for TON to occur, and there remains controversy as to whether doing surgical decompression of patients in this setting is really important. What that means is that there are surgeons who will take this patient to the operating room, usually it's an ENT surgeon, going endoscopically and decompressing that canal. And in modern ENT surgery, modern hands, it's actually generally quite safe and usually quite successful in terms of the technical aspect of it. But the question really is, did that fracture and the transfer of energy lead to such a significant injury that regardless of fixing that fracture or unroofing that canal, you're not going to lead to an improvement in the visual function? So that's really the concern that I have with doing surgery on these patients. It can be done, and there are great series out there that suggest that it's useful, but I'm still not sure. Now, I take care of a lot of patients with traumatic brain injury as well. And it was suggested that patients who have head injury and are hospitalized, at least 8% of them might have a traumatic optic neuropathy. And if you look at that at the first line here, but this was again a hospitalized population that were very severely injured and were sent to neuro-ophthalmology. In a prospective study, the second line there, 200 patients with traumatic brain injury, only one of them had TON. And in fact, if you look at facial trauma patients as a whole, over 5,700 patients being studied, only one had likely TON, 19 had vision loss, typically from other causes in the setting of facial trauma. So what you should remember is that patients with TBI may have had traumatic optic neuropathy, but it's uncommon. Now, there is an association between severe eye injury and TBI and optic neuropathy. So this was a study published out of the United States military where it was demonstrated that this could occur. Now, in an outpatient setting, two last points for you. Traumatic strabismus and diplopia may occur from minor head trauma, and fourth nerve palsy is one of those, right? But when you have a third or a sixth nerve palsy in the setting of minor trauma, you need to be concerned that there may have been a pre-existing lesion of some kind that might have predisposed the patient to having an injury of that nerve and then resulted in the trauma. And so other causes that might happen, supranuclear causes can occur. There may be other causes of sudden onset cranial nerve palsy, not likely that it's ischemic, but just again, keep your differential diagnosis broad. And in general, when I take care of patients with traumatic strabismus, I follow typical guidelines in terms of waiting until they're stable and then operating. The final thing I'll leave you with is that TBI and other visual disturbances can occur. It's not just traumatic optic neuropathy, it's a lot of ocular motor disturbances. These are still not well characterized, and we are doing further studies to better understand them. This was a series of military patients with blast or non-blast related injuries, and don't dismiss their complaints as being malingering or otherwise just they're upset about their injury. These are real problems that occur. So in summary, there's no proven TON therapy yet. Traumatic strabismus requires patience. We need to investigate to make sure there's not a lesion, but patients may improve, and if they don't, you can operate. And remember that your TBI patients may have non-specific symptoms in an ocular motor system. Thank you for your attention.
Thank you so much, Professor Prem Subramaniam, for those wonderful snippets. I have a couple of questions for you. You mentioned there may be some patients who, in the setting of trivial trauma, can present with third or sixth nerve palsy, and these are the patients that we need to be careful about. Is this only in the case of trivial trauma, or if there is a significant amount of trauma, would you say that third and sixth nerve palsies can be acceptable or can be expected?
I mean,
how trivial is trivial? Yeah.
Sure. I'm usually looking for, so with traumatic third or traumatic sixth, I'm usually looking for hemorrhage at the level of the brain stem. So often you'll see, if you look carefully with CT or MRI, that you can see hemorrhage in the fascicle of the third nerve. And that is an indication of the trauma that was done. Similarly, if there's sixth nerve palsy, I'm looking for skull base fracture, which is often coexistent with the traumatic sixth nerve palsy. So you're right, you don't want to ignore these things. You want to look for appropriate signs. But if it's a high-speed MVC, for example, then I'm going to be less concerned that there may have been some other lesion present.
Right. Thank you so much. And one last question. We always, our practice patterns in the Asia Pacific, specifically the Indian region, is still evolving away from steroids, and it's not uncommon to see patients of traumatic optic neuropathy still being prescribed steroids. Keeping in mind, it's election season back in the US, so it's like one of those questions where I'm going to ask you your position on this. What are you going to say to anybody who thinks about prescribing steroids for traumatic optic neuropathy?
So unlike a politician, I'm not going to belittle you for making your choice, but I will take a strong position. And that strong position
we're not going to present any fake news.
And that strong position, which is backed up by data, is that the one randomized study of steroids and traumatic optic neuropathy did not show any benefit. If you look at various case series, I think they do not demonstrate strong evidence that steroids are helpful. There is some animal data that steroids might even be harmful. So my position is I no longer treat my own patients with steroid when they have traumatic optic neuropathy. And if others seek my advice about their patients, I tell them the same thing. I would advise them against it, because not only because I think it doesn't work, but if the patient has a head injury as well, there are data that steroids could harm that patient with a head injury.
Akshay, can I take up one question?
Sure, sir, please.
Because the Deepavali, hi, Prof. Subramanian, Rupesh here. So basically,
yes.
Diwali season is coming up, and we have also one-eyed patients in our clinic. So, and I know your passion about the protective eye wear. So, what's the message for all of us about the protective eye wear? Should we be wearing it, and then what kind of things are there for one-eyed patient as well as to protect your eyes? Yeah.
Sure. So absolutely. So from my time in the military, I'm a great advocate for eye protection. And I think the lesson I learned is attractive eyewear is important. We tried to get soldiers to wear things that look like after cataract glasses, and they absolutely refused. Things that look like the safety glasses that people on construction sites in the West wear. So they need to be sleek looking protective eyewear. It needs to be the kind of things they see sports players and other people wearing. Most of those things now are made of polycarbonate, so they work very nicely. And so the message for our patients is, if you want to look cool, you should wear eye protection. Look at the sporting people out there. They're wearing eye protection. They're protecting your eyes. And I think that's the message that comes across to our patients. You want to be cool, protect your eyes, and then go and do what you're going to do.
Thank you. Makes sense.
Right. Thank you so much, Professor Subramanian, for your time. We have with us now the winners of this neuro-ophthalmic session. In the under 40, the winner is Dr. Smriti Dabas from Delhi. And in the above 40 is Dr. Anika Chalam S from Pondicherry. Congratulations to both of y'all. We will be reaching out to you soon. And we see you joining us. So with that, we now move on to section 5. Dr. Shilpi.
Yes, sir. So welcome back. This is the last section of today's quiz. So tighten your seat belts. This is the last chance to be a section winner. And yes, you can be a runner-up and winner for the whole session. So first question of the last section of this quiz is, so do you remember this famous footballer? Yes, he is Paul Scholes. This famous footballer suffered from which ocular condition? Option A, glaucoma. Option B, cataract. Option C, retinal vein occlusion. Option D, traumatic optic neuropathy. And your time starts now. Yes, he suffered from retinal vein occlusion. This famous footballer played 11 Premier League titles, but the greatest surprise is that he played a part of his career with one bad eye. So coming to the second question, true about Terson's syndrome is, it is seen in diabetic or hypertensive patients. Option B, surgery is indicated as an emergency, or FFA is diagnostic in this case, and the option D is observation or conservative management is advised in acute stages. And your time starts now. I think this is a very easy question for everyone. And here the answer is observation is advised in acute stages. Yes, this Terson's syndrome, it is seen as an intraocular hemorrhage post head trauma. Management is usually not indicated as it carries a good prognosis. It resolves spontaneously. Only in non-resolving cases, vitrectomy is advised. So the third question of today's last section is, all are features in sympathetic ophthalmitis except option A, lymphocytic infiltration of uveal tract is seen. Option B, there is absence of necrosis. Option D, it involves the retina and choriocapillaries. And option D, Delenfuge nodules are seen in this case. And your time starts now. So which feature is not seen in sympathetic ophthalmitis? So time up. I think everyone must be knowing this answer. And the correct answer is involvement of retina and choriocapillaries. This is the condition where retina and choriocapillaries are usually spared. Incidence is 0.19% after a penetrating injury and 0.007% after any intraocular surgery. The most common differential diagnosis is VKH, in which you will get associated systemic features and there is no history of any penetrating trauma. So coming to the second last question of this session, following blunt trauma, retinal dialysis is most commonly seen in superonasal and inferonasal quadrant, inferotemporal and superonasal quadrant, option C, inferotemporal and superotemporal quadrant, and the last option, that is option D, superotemporal and superonasal quadrant. And your time starts now. So the correct answer is, yes, it's option B, inferotemporal and superonasal quadrant. The coupe and counter-coupe mechanism is responsible for 180 degrees apart dialysis. If you look at the construction of the orbit, the superior and nasal quadrants, they are protected from direct injuries by bony elevations. That's why we get the dialysis most commonly in inferotemporal and superonasal quadrants. So this is the last question of this session. Solar eclipse retinopathy are true, all are true except option A, it usually resolves by self in 6 months, or option B, damage is by photochemical phenomenon, option C, FFA reveals transmission defect, and option D, damage is by photothermal phenomenon. And your time starts now. Yes, so answer here is solar eclipse retinopathy is seen, the damage is by photochemical and not by the photothermal phenomenon. Symptoms are usually decreased vision, but it usually improves within 6 months. In late cases, sometimes you can see a transmission defect because of the RP irregularity on FFA, while in the acute cases on clinical examination, you will see a small yellow spot with gray margins. OCT is a classical which shows a reflectivity and cyst-like spaces in the outer retina. So here we come to the end of this quiz. No mega event is possible without the generous contribution by pharma. I personally take this opportunity on behalf of OTSI and Brain Teasers to thank CIPLA for supporting today's quiz. Here is a small video clip from CIPLA.
Caring for life also continued for the ophthalmologist fraternity during the times of crisis. Similar foresight handed over masks, PPE kits, gloves, and sanitizers to frontline health workers. Clinic sanitization was done in multiple clinics across India. Similar foresight offers various services to support your ophthalmic practice, like Navia eConsult, a teleconsultation platform, Wealthy App, a lifestyle management platform for patients with diabetes and hypertension. Foresight, digital connect to share information on product availability. Partnered with doctors in the scientific initiatives by conducting more than 150 webinars.
So friends, people who have missed today's live quiz as well as previous episodes of Brain Teasers, you can watch us on YouTube and Facebook. Now it's time for all of us to chat with the experts. By the meantime, I request all the winners to join the platform so that we can felicitate you.
Thank you so much, Dr. Shilpi. Dr. Rupesh, Dr. Natarajan, can we have you all turn on your videos so we can speak to you all? Dr. Shukla, Dr. Mukherjee. Great. So, Dr. Rupesh, I'm going to start off with you, and I have Dr. Natarajan's input on this also. Very often, in our Indian clinical scenario, we see patients with extremely severe trauma, almost, deformed, completely disfigured eyes with partially auto-eviscerated cases. In medical colleges and in smaller setups where there is primary care being given, oftentimes they are advised an enucleation or an evisceration at that stage. What is your position on this, and what do you think should be done, and what is its implication towards sympathetic ophthalmia?
Thanks, Akshay. But I thought we had a deal of asking a simple question to me. You were asking a bit off-track question to me. This was not the deal. But let's see. Anyway,
So you have Dr. Natarajan's backup to.
Yeah, I know he's going to support me. Therefore, my profile picture is looking to the left. Your profile picture is looking to the right. So each one of us is looking at each other. Anyway, coming to the point, I think, we had severe instances not only in India, but I can say that is in context of Singapore also and overseas also, where we get patients with the severe eye injury, which can be no light perception. So let's take that extreme example. And most of the residents and the junior doctors who don't have much experience, their first thing is that, okay, let's remove the eyes in fear of sympathetic ophthalmia. So that's the fear still people have. But over a period of time, definitely we have learned that sympathetic ophthalmia, A, it's not something common. B, even if it happens, there are ways to treat it. And as we have seen very clearly in Professor Peter Michael's lecture also, so we know how to treat it. We have medicines and we have the way to manage it. So I will not probably suggest in cases with severely traumatized eye to kind of go for removal of the eye, for mainly for possibly there is some scope for vision restoration, but also to buy in time to prepare psychologically the patient so that at least they will feel a doctor and his team has given good amount of time to prevent the eyes. Because immediately if you remove, that leaves a kind of a very severe mental impact on the patient. And I'm sure Dr. Natarajan will agree with that particular point of the psychological impact on the patient, which sometimes we ignore that part of the trauma management. Because that's one of the 4 pillars which Professor Poon has said in his book, is to minimize the further trauma and minimize the further trauma to the eye and mentally to the patient also and to his family. What do you think, Dr. Natarajan, on this point?
I definitely agree, and I made it as a policy. No primary enucleation or evisceration. That's what I give a talk. And I quote Ferenc Kuhn's papers on operating on no PLIs, only in ocular trauma, along with Bob Morris. And I think there are even Dr. Peter McCluskey. So I think however bad, I remember even Klaus Hyman presenting in 92 in this trauma conference, that is the second trauma conference, saying he did a 9-hour surgery for a trauma with a total scleral graft and other things to repair the eye, only to secure the shape of the eye first, and then the second procedure for doing the vision restoration. So I think there's no need to be having fear for sympathetic ophthalmia. We should do meticulous repair and make sure there's a saying that you operate on an eye as though the eye will survive, and not that someday we are going to enucleate or eviscerate. And I also do, I think multiple surgeries happen. Recently, I referred a patient to Akshay where there was a road traffic accident and we attempted the surgery, and then the eye is in tricycle now. But at least we have given a fair chance to the patient, because the patient was very upset that the vitreoretinal surgery was not done, with thinking that the prognosis was poor in Delhi, and they came with a 1% chance. I attempted, also taking a video consent of sympathetic ophthalmia may happen 1 out of 100,000. And also I explained to them that you should know this, and then refer to a oculoplastic surgeon like Akshay to do, so that they know that everything has been done, and now oculoplastic surgery can be done following reconstruction after removing the eyeball, knowing well that nothing can, like a retinal transplantation or patients have this, public has this question. But I think we have done the best for the patient, and then do the oculoplastic surgery.
Excuse me. Yeah, can I say something?
Sure, sir. Sure.
Yes, Mehul.
I think my Dr. Rupesh Agrawal has got a joint publication for no PLIs, and in 29% cases, this was comprised of 429 cases. In 29% cases, we have seen improvement in some form of vision in all no PLIs, ranging from PL to 1/60. So I think it is very important to treat the no PLIs and rather than leaving those eyes.
So I agree with Dr. Mehul. Even in our data in Singapore, out of 180 eyes, there were 35 eyes which has better vision than PL. And out of those eyes, there were around 50% of the eyes with a vision between 618 to 636. I think we have a very good chance of salvaging some of this thing. And this is, look at the 10-year data from Singapore also, which we also published.
Yes.
But thanks, Mehul, for coming.
I too would like to add, only a month back, I received a young boy in the morning. He was walking, early morning walking, was hit by a snatcher over his eye, in which he had a globe rupture with the exclusion of the lens vitreous. So he's been advised with evisceration somewhere else. Being a young boy from engineering college, they forced me to just repair it. Just on a very extensive injury, you see, right? 7 o'clock till 12 o'clock, and then going beyond the equator. So after exploring, we repaired it, and we followed that patient, and fortunately a day after, there was a globe formed, unexpected to my expectations. So we did a Doppler, which showed me not much choroidal edema, so it was well formed. So we followed him for a week further. We could see the PL positive. That encouraged us to go ahead with that. And another 1 week later, we planned a vitrectomy earlier as usual because of the extensive blood inside the anterior chamber. So we are lucky now. He, after say 6 weeks post-op, he's 660 to my surprise and surprise to his parents. And I believe in the previous webinar, we were discussing early and quick repair is the long way help to a patient and to the surgeon. So I do advocate early and quick and repair in all those patients with a PL negative even. Thank you.
Welcome, Dr. Grover.
I think Dr. Shakeen, what I
Right,
said,
sir.
in ophthalmic surgery, I learned from mentor Dr. Badrinath, there's no luck. Everything is karma. And I think that's what we are discussing here. No enucleation. I think that's why I mentioned in my comment that you have to operate as though the eye is going to be all right, and then the eye will see. So I think 660 vision, the patient. I think credit to you. Yes, sir.
That is the problem comes in that most of the time in the smaller medical colleges or the peripheral hospital, these cases go to the junior most person.
Yeah.
Because they come in the emergency and ultimately they are given the chance to handle those cases. And there the problem starts. If they are taken care in the proper trauma specialized clinic, naturally they will be repaired properly and chances of sympathetic ophthalmia will definitely be reduced. The eyeball will be maintained. These days, actually, no eyeball should be removed unless you are sure that this eye cannot be saved at all or something happens to the rest of the part of the body. The anatomical integrity has to be maintained at the first sitting.
No, but we cannot assess whether the something can be restored, sir, on the time of injury. So I think that's why we say whether you can restore or not. At least you have to restore anatomically, and then functionally we have time. And I think there was no need to enucleate even within 2 weeks, or even if there's no. That's why I think I remember in late 80s we were thinking within 2 weeks if the patient doesn't come back we have to enucleate. I don't think it's required because we can manage the patient well.
Not at all.
So I think the take-home message is don't fear sympathetic ophthalmia, even if it happens. And I remember Dr. Vishwas quoting even an earlier article in 80s or 90s from Japan, calling it as a bilateral uveitis. And today we saw Dr. Peter McCloskey telling it's an autoimmune, all similar. So we can treat with the autoimmune, like anti-mitotic drugs and steroid and save the sympathetic ophthalmia. But if you lose time, then I think there's a risk. So I think you have to identify, that's why I quoted Parsons' definition of sympathetic ophthalmia. The earliest sign is difficulty in reading or because of the accommodation. And I think the patient should be not taken light and the consultant should check the eye without dilatation. And that's why I think the pupil is very important in those eyes, in the fellow eye.
Right, sir. Thank you. And I'd like to welcome Professor Grover, sir. Good to see you. We enjoyed your presentation earlier.
And without looking at you, Ashok, we thought that Ashok Ghost was presenting.
Thank you, Nati and Akshay and Prashant. I apologize for the delayed entry because Ocular Plastic Society of South Asia webinar just finished, and I was obliged to be present. I agree with you that never say never in trauma. I think you never give up. That's the lesson that we have learned over the years. And I think we face this most in the cases of deformities of the eyelids and the periorbital region, which occur due to inadequate primary repair or delayed primary repair. And there are miraculous things that you can do with multi-stage procedure, tackling the bony defects, tackling the eyelid positions, and especially the canthal fixations. Those really make a huge difference to the appearance of the patient. And aesthetics on the face is so important that besides the functional, you also need to ensure a good aesthetics by all means that you can do multi-stage procedures. And those are some of the most challenging and some of the most rewarding cases that we do. And thank you, Prashant, and thank you, Dr. Mukherjee, Dr. Natarajan, everybody for the talk and for letting me be here.
You're not yet over. You have certain further obligations to perform. Akshay, there were some questions for Dr. Grover, sir, also you need to ask him because the viewers would be interested in knowing. Now he's present to you better.
One of the questions was that you mentioned about canalicular tear repair. How, if a patient presents, what sort of a delay would be acceptable for you to go in and re-explore and try to canalize the canaliculus versus abandoning if the patient presents, after a significant delay? Are you still hopeful, or what is your cutoff in terms of time?
Never say never.
Sorry.
But yes.
Can I interrupt, sir?
Yes,
just interrupt. Before A.K. Grover sir answers this question, we'll declare the section winner as well as the session winners, Dr. Shilpi, to do that needful so that they can join us on the Zoom platform and we can continue with the discussion by the time they join us. Please, Shilpi, please. Section 5 and runner-up.
So, section 5 winner, less than 40 years of age, Dr. Matthew K. Johnson from Ernakulam. Congratulations. And for section 5, more than 40 years age group, Dr. Rajesh Patel from Bharuch. Congratulations, sir. Now it's time for runner-ups. Runner-up in less than 40 category is Dr. Ravija Kathira from Ahmedabad. And
Ravija.
Ravija. And in category more than 40 years, it is Dr. Shailaja Ketkar from Nagpur. Congratulations. Now it's time to declare the winners. So winner for today's session in category less than 40 years is Dr. Muthukrishnan from Chennai. And in the category more than 40 years is Dr. Thanika Chalam is from Puducherry. So congratulations to all in one. Please join the platform as soon at the earliest.
All the winners, please join us on the Zoom platform. We have already sent the link on your registered mobile number. Do join us. Meanwhile, we continue with the discussion. Akshay, over to you, please.
Yes, Professor Grover, sir.
So Akshay,
the question.
it has been shown by studies that up to 5 days, the results are quite good. You can be nearly 90-95% and above if you operate within the first 5 days. That's why we prefer to operate in your own proper operation theater under proper conditions with your proper assistance within the first couple of days, preferably, but up to 5 days is fine. But even after that, sometimes you get lucky. The fibrosis may not be so much, and you can explore within the first few weeks and sometimes find the medial cut end as well with a little exploration with injection of air from the opposite side or injection of a little fluid, milky fluid from the opposite side, or even a dye. And you can then carry out pericanalicular suturing and leave in a stent. Stent generally we leave only for about 6 weeks now, and as we said, mini Monaca is the material of choice these days, and it does work in many cases. But of course, chances have decreased after 5 days, and you may end up with a fibrosis when you remove the tube, or you may not succeed in finding the medial end, and you may not be able to do it. So preferable to do it early, but never give up even when late.
And when the case is really recalcitrant, you just send it to Dr. Grover, sir. He will handle it.
As always.
As always.
Right.
Thank you.
Thank you. So the other question that more than a question, it's probably something that can elicit a discussion. I think ocular trauma in general is not just about how to manage, and we know it's about creating awareness, also about in letting people know about improved techniques to manage trauma, and also rehabilitation. But in terms of advocacy, we seem to be lacking a little behind. Say, for examples, about advocacy from our group to allow rehabilitative surgeries following ocular trauma to be included into insurance, to be covered by insurance, or say for these, because these are common complaints that we have patients telling us. Recently in the US, the Black Lives Matter and the other protests that happened brought to the forefront the use of rubber pellets, and the American Academy of Ophthalmology has strongly advocated against that, and even pushed forward a couple of legislations against the use of such rubber pellet. So what, according to the office bearers of OTSI here, do you think should in the Indian scenario are things that advocates should be at the forefront, that the society could advocate for at the governmental level or the legislative level?
So in the World Ocular Trauma Congress, Rupesh had prepared about 3 years back a document, almost 50 pages, which we have it with Dr. Ashok Grover and Dr. Mukherjee. In December, we got it signed. And I have requested All India Ophthalmic Society. We have made a committee, both for endophthalmitis and ocular trauma. I hope to get a PIL against crackers. And I have actually given points that the Delhi High Court has given because of the air pollution and sound pollution, they have given timing. So based on that, Dr. Mukherjee is working on, and we hope to get an advocate who will file a PIL against the crackers. And we should ask for a ban, which is not fair, but I think if you ask for a ban, and maybe they will come with a public for cracker. Similar thing, as you said, for pellet ocular trauma, there was I circulated the president of American Academy's mail where they quoted my article in 2016 in the New York Times, as well as they quoted 2019 Chile rubber bullet injury. And then now in June, after Clive Lloyd, George Williams gave a talk saying that the injury is like taking a hammer and hammering the tomato, and then the ophthalmologist have repair the eyeball as a torn tomato. So I think we are in the process of advocacy, and if at all it goes through, all the hard work is done by Rupesh as the base work, and which is what we are working on. And I think Rupesh and probably Dr. Mukherjee will comment on that, because we are working on it. I know Rupesh is frustrated because we are not able to move the government, and but we will. I think one day we will. Rupesh and
Yeah.
Dr. Mukherjee.
Thanks, sir. I just shared, probably the approach was different, and I was just going through in this time certain skills of leadership or something, probably something which we lacked. And this is picked up from one of the references from leadership. I think we need to take into consideration, this is called as performance prism. And where we need to get it is probably buying from all the stakeholders, whether it is OTSI, APODs, and even government or anywhere where we need to define the stakeholder, come up with the strategies, what we need to do, and define a process, and at the same time identify capabilities. So this is more theoretical, but I think we need to form, probably I will take a step back. Let's form a committee, which can be, Prem is not here, but we can have probably an international committee. OTSI can take a lead, and this committee can then report back to OTSI and then see how we want to move it forward. So I think that can be probably more constructive way to look into it. And the role of this committee is to kind of brainstorm, how do you want to bring in this change, whether it is acceptable by government or the people on the ground. I think what Akshay's comment is, if we have to bring in a change, probably we need to go back to our blackboard and then redo a little bit of homework, whether it is a statistics, data and all. Otherwise, we are going and beating around the same thing again and again. We'll not be able to achieve anything. So this is probably my little new thought, just based on 3 months of my reflection of what we have done and probably what we could have done better. I don't know whether people will agree, but that is what I will probably suggest here.
So we
Thank
are
you. Dr. Prashant?
Yeah, I think so. With your motivation and with your guidance, definitely OTSI is going to take ahead the advocacy part for the benefit of our Indian continent as well as the world across. We are going to work hard under the stewardship of our President, Dr. Mukherjee sir. So now, friends, it's the time for us to acknowledge and felicitate our winners who are now on the live.
Can I just add one or two words?
Yes, sir.
And in advocacy, can I add one or two words?
Please do, sir. Please.
Look, actually, we have started the advocacy from the beginning, and that is our primary motto also in OTSI. We have taken help from the Rupesh and other people who are working on it. And wherever possible, even in the states, all the states of India, wherever possible, we go and try to impress them about the ocular trauma. By this process, actually what we achieved in last 2 years, now the ocular trauma society is at least recognized by most of the people, most of the societies. Earlier it was not that much what was there, but because of our persistence, we are getting this thing. Top of that, we I think personally that going to legislation or going to court or going to some politician, it is not going to matter that much. We'll have to do ourselves and take help of the NGOs or the school teachers or the factory personnel. From those people we can get a lot of help, and we can teach them how to do the advocacy on particular project, because advocacy is not equal in all the places. School children, it is absolutely different. A factory worker, it is another type of thing. So we have to go to those places in their place and do the advocacy rather than straight away. Legislation has got its own merits, and we'll have to do that ultimately. But totally, we should not depend on the legislation.
I think what Dr. Mukherjee said is perfectly true. Advocacy has to become a culture of the organizations,
Right.
all professional organizations, including the AIOS, including the OTSI, as has been done in AO, where when the member joins, they are put into advocacy committees. Because unless you work at all levels, starting from the corporation level to public education level, to education of judiciary, to education of politicians at all level, district level, state level, and the central level, it is not going to work. The politicians will only work when there is enough education in the public to say that this is what is required, and it will start working. So it requires a sustained effort. What I do find is that whenever an advocacy is done with enough preparation, with enough background material, the bureaucrats as well as the politicians are quite responsive. But it requires a sustained push from us, repeatedly reminding them, and then things do happen. So if we do push, we will be able to do it.
So Dr. Mukherjee did the advocacy as a part of the Silver Jubilee last month. And as a part of that, Dr. Professor Francine from Brazil, Sao Paulo University, she has actually sent me a proposal having a joint project between her Rotary district through the governor. And she has asked me to get in touch with the Rotary governor here so that we will have the Rotary as a part of the advocacy and make it as an entire Rotary India to work on this prevention of eye injuries and advocacy.
Thank you, sir. So what we gather here from the discussion is that it is the need of the social advocacy and change in the cultural values of the public at large. And if we attain that through our societies, I think the government will be pressurized to naturally get into changes and get into legislative way. So now, friends, it's time for us to felicitate our winner. And the first section winner, section 1 winner, is being felicitated and interacted by Dr. J.K. Das. So winner in the section above the age of 40, Dr. Kamal Kishore, he's from Illinois. So we have the first winner on the Brain Teasers from USA in section 1. Dr. Kamal Kishore, have you joined us on the platform? Sai, is he there?
No, doctor, he is not reachable, doctor. His mobile not reachable.
So we can congratulate him on behalf. And Dr. Muthukrishnan, are you there? Sai, has Dr. Muthukrishnan joined us? Hello?
No, doctor, we've informed him, but he's not yet joined.
Okay. So can you just reflect upon the vouchers who were to be felicitated by Dr. J.K. Das? So Dr. Muthukrishnan, congratulations. You are session 1 winner in the category of less than 40 years. And J.K. Das would have handed over this particular gift voucher to you. We are definitely missing you. Now we move to the section 2 winner. So Dr. Shakeen Singh, are you there, sir?
Yeah.
So Dr. Shakeen Singh will be felicitating and interacting with the winner more than 40 years, Dr. Mohammad Irfan from Mumbai. Dr. Mohammad, is he there with us, Sai?
No, doctor, he has also not joined, doctor.
And then PV Jayashree?
Yeah, I am here, sir.
Yeah, good. So Dr. Shakeen Singh, she is a winner of session 2 in the category less than 40 years.
Dr. Jashir?
And interact with her.
Is it Dr. Jashir?
Yes, I am Dr. Jayesh. Yeah, I can hear, sir.
Congratulations.
Thank you very much.
It's really good you have won this prize, and it's really very good you have a great interest in trauma. What is your basic? What your basic specialties?
Sir, I'm a glaucoma consultant in Narayan Nethralaya at Bangalore.
Okay, are we dealing trauma day-to-day practice?
Yeah, we do see a big part of trauma patients do come to us because they have primary IOP increase and also secondary glaucoma. So we do see multiple types of glaucoma, multiple types of trauma and related glaucoma also.
That's great. Do we have something incorporated in our practice to prevent trauma or trauma prevention education to the society or in any other hospital?
Definitely, sir. Especially regarding this crackers and all, we do have information and videos always telecasted in our Facebook and other media, sir.
Thank you, Dr. Jayashree. It was nice interacting with you. Keep on playing Brain Teasers. We are there, always there on first Sunday of every month. This was a specialty week, so we were there in the mid-month of it. Congratulations.
We are going to announce another gift to all the winners. So
yeah, please hold on the line. Our president is something up his sleeves. He's going to give you some special prizes after this. So now the session 3 winners will be felicitated by Dr. S. Natarajan from Mumbai. And the first winner, that is winner less than 40 years, Dr. Anu June from Delhi. Dr. Anu, are you there with us?
Yes, she's there.
Yes, sir. Yeah, I'm there, sir.
Hi, Anu.
Good evening, sir. Good evening to all of you.
Congratulations, Anu.
Thank you, sir. Thank you so much.
Anu is our LDP alumni. So I'm proud of her.
Thank you.
Anyway, I can tell her that she's working in a government hospital in Delhi. Yes. And you can tell more, Anu, what's your interest?
Sir, I'm working as an assistant professor in Maulana Azad Medical College and Guru Nanak Eye Center. And I work in the specialties of strabismus and glaucoma along with ROP. And yes, trauma is a part of everyday life for any ophthalmologist for that matter. And my trauma exposure began right in my senior residency, where we would operate cases during our night duties. And like you rightly said, in a lot of institutes, what happens is the trauma goes to the junior most. So it's not exactly the junior most person, but yes, a senior resident or a junior consultant who operates trauma. So what my take is, it is really important to have good hands and good surgical skills while operating a trauma, because the finer you operate, the better the prognosis the patient has. So tissue handling and operating in a very good, fine way and good apposition goes a long way in the repair and visual prognosis of such patients.
Congratulations, Anu. And then we have Dr. Gaurav Majumdar.
Do we have a trauma center there, a trauma unit there in Maulana Azad? Dr. D.K. Mehta would have been here, and I'm sure he was a great advocate of this thing. Do we have still a ocular trauma unit or ocular trauma surgeon there in Maulana Azad?
No, so there's no special unit of ocular trauma, but
never
all
mind.
the units do operate trauma depending
So
on
that's the key thing which is missing, Dr. Grover sir, Dr. Natarajan sir.
Yeah,
We
Dr.
have
Ritu Asra
units.
is known to us, and I hope.
Again, this is the thing which we have to get, because it becomes everyone's baby. It is not going. If it cornea, then it goes to simple corneal ulcer, corneal abrasion, will go to a cornea unit. A simple retinal tear for retinopexy and lattice degeneration will go to retina. But corneal trauma, scleral trauma, lid trauma go to everyone and everywhere. So I think if we can probably think about it, and I've been speaking about it for quite some time. So I think that's the fundamental change which we need to bring in. I don't know when it will happen.
When we develop an interspeciality coordination.
Correct. Yeah, exactly.
If we have trauma units which make sure that they involve all the subspecialties to provide the best possible
But
care.
basic, I've been saying basic 30% open globe injuries, simple trauma which does not fall into any subspecialty should be taken care by one unit. And then they work with oculoplasty, then they work with retina and all. But there should be some person who should be there in all the major institutes across India who is handling the trauma. Then that is the time when we can have a registry, and that is the time we can change.
Correct.
We take it very well. In fact, Grover sir is a person who is trying to format the postgraduate courses for us, various courses for fellowship in our country for AIOS, and I'm sure Dr. Grover sir would definitely pay heed to the suggestions given by you regarding ocular trauma.
Sure,
now the session 3 winner in the category more than 40 years is Dr. Gaurav Majumdar from Calcutta. Dr. Gaurav, are you there?
Dr. Gaurav?
Sai, Dr. Gaurav is there?
He logged in, doctor, but for some reason he's logged out.
Oh.
Okay. So we congratulate him once more.
Yeah, congratulate Gaurav. And what is the price for them, Prashant?
So it is a 6,000 rupees gift voucher.
Oh.
And also they get a certificate besides that.
Anu, what are you going to do with the 6,000 rupees? Anu?
Buy firecrackers.
No, sir, I stopped firecrackers since almost the past 15 years.
Very good. But what are you going to do? You have
No
idea?
firecrackers. No idea yet, sir.
Okay.
Okay. So now we move to the next section, section 4 winner, Dr. Mehul Shah. Sir, you are going to felicitate Dr. S. Thanika Chalam from Puducherry. She is a winner of above 40. Is Dr. Thanika Chalam from Puducherry live with us? Sai?
Not what is that?
Not in clinic or home, doctor. He's gone out, it seems.
No issues. Mehul,
Anyway, congratulations.
Yeah. And Dr. A.K. Grover sir is supposed to felicitate Dr. Spriti Dabas from New Delhi. She is a winner in section 4 in the category of less than 40 years. Dr. Smriti, are you there with us? Sai?
He logged in, doctor, 1 minute.
Dr. Smriti, can you hear us? We would like to see you. Unmute yourself.
She is not there.
So
She sent
me a WhatsApp saying there's a network issue.
Okay.
Let us just congratulate her and wish her all the success in her life.
Okay. Thank you, sir. Thank you. Now we come to the section 5 winner. And I would request Dr. Rupesh Agrawal from Singapore. He's going to felicitate and interact with the winner. In the category more than 40 years, it is Dr. Rajesh Patel from Bharuch. Dr. Rajesh, are you there?
They have got the problem of getting link.
Sai, is it there?
Not there, not there.
Okay. Dr. And Dr. Matthew.
Yeah, he's there.
Matthew Joseph from Ernakulam.
Yeah, he has to unmute. He's there. Dr.
Please
Matthew.
unmute yourself. And Dr. Rupesh.
Hello, Dr. Matthew.
Yes, sir.
Yeah, first of all, congratulations, and really, really proud to see you here and getting this prize. So, what's your
Thank you, sir. Sir, I'm a general ophthalmologist. I'm working as junior consultant in Kerala Government Health Service. Presently doing only COVID duties.
Yeah, but besides, when you are in the general practice, do you get trauma, and how frequently do you get ocular trauma cases?
Yes, sir. Ocular trauma is there, but since actually I'm working in a fairly remote place, and I'm just trying to introduce cataract surgery, phaco, everything in my place, and in the process of development only right now. I'm doing phaco surgeries, but presently only COVID duties and ocular trauma and or at present it is only not so much.
But that's good, and I really encourage you and want to congratulate you and wish you best luck. Means you try and kind of propagate about the trauma thing and the wonderful work Ocular Trauma Society of India is doing in India. So I will encourage you and your other friends to become member of Ocular Trauma Society of India and kind of learn whatever they are trying to teach. They are having monthly webinars and lots of activities. So I think it will be a really good, because it's a kind of a virtual institute which is there in India through efforts of Dr. Grover and then Dr. Natarajan and now Dr. Mukherjee and all. They have done a lot of, and Dr. Shukla is there on the line as well, and they have done a lot of efforts. So I think you should encourage everyone in Kerala, and particularly less than 40. And if you can lead a young ophthalmology trauma chapter, so I know there is a lot of young ophthalmology thing going on. I'm not part of that, but I know that there is a thing. So probably you can start a young ophthalmology chapter. That will be really very wonderful. And I'm sure Dr. Grover and Dr. Bhavan Kulesar will guide you. How do you go about it? But I think all of you should become part of Ocular Trauma Society of India to take to the next step.
Which town you are working, Dr. Matthew?
Ernakulam.
I'm working in Thodupuzha in Idukki district.
Idukki district, okay.
Great,
Yeah.
Dr. Matthew. We are really proud of our fraternity who are the COVID warriors of from our own fraternity. We are proud of you, in fact. And in spite of your busy and such a demanding COVID duties, you are here to play the quiz, ophthalmic quiz, that to trauma, speaks about your commitment for the subject as well. We salute you, Dr. Matthew, for your commendable effort towards COVID. As an Indian, as a small Indian, I would love to salute you. Congratulations once more, Dr. Matthew.
Yeah, just Dr.
Yes, Dr. Das.
Yeah, I just want to request all our senior office peers and senior doctors, so we can think to help our young, very intelligent ophthalmologists. Those are working. So there is a lot of trauma that lots of people are running behind only the SICs. They are very good surgeons, very, very intelligent. And so in our future, and to Dr. Rupesh also, to just make some program for our young ophthalmologists, those are working in a rural area, because maximum traumas they are basically handling those things, and they refer that to the in a proper time to the senior in a cities. So we can think in future from OTSI and from other societies to how we can help our rural ophthalmologists. Those are working in the rural and they are very intelligent. They can do lots of work. Any idea, Dr. Rupesh?
Yeah, Dr. J.K. Das, what we plan to do for OTSI, I think I've spoken loud about it to Rupesh also, that we need to create pearls in ophthalmic trauma from all the senior people across the country, across the world, and create a video bouquet of all these small snippets, which will be handy and helpful, which will be available on our website. So let's see how it evolves over a period of time. So let's move ahead with the presentation ceremony, because the winners are really eager to and eagerly waiting for their names to be declared. So coming to the runner-up category, Dr. Ashok Grover sir will felicitate a runner-up category in the category of more than 40 years, and she is Dr. Shailaja Ketkar from Nagpur. Dr. Grover sir is supposed to felicitate. Is Dr. Shailaja Ketkar with us? Hello, Sai?
Yes, she is, Doctor.
She's there?
Good evening, Dr. Shailaja. Can you unmute yourself if you are here?
Hello. Shailaja madam, are you there?
She's not there. Prashant.
Oh, okay, she's not there. Okay, we
She's there.
congratulate her.
Not unmuting herself.
Shailaja madam, please unmute yourself. Can you hear us?
I don't know. I can't see her name.
Okay. Okay, meanwhile, we move to the next, that is runner-up in the category less than 40 years. And I request Professor B.K. Shukla sir to virtually congratulate her. And she is Dr. Ravila from Ahmedabad. Dr. Ravila, are you there?
Ravi Jha, no?
Yes, ma'am. Yes, sir.
Yeah. Where is Professor Shukla sir there? Ravija?
Yes. Sir, unmute yourself. Dr. Shukla, unmute yourself.
Sir, she is a runner-up in the category less than 40 years. Dr. Shukla sir. And she's a young girl. What is your advice to her?
Dr. Shukla, unmute yourself.
I think Grover sir, can you? Yeah, great.
Ravija, we are really grateful to you for having participated in this, and we really want to congratulate you for your excellent effort in being the runner-up of this program. And we hope that you will be an advocate for ocular trauma and carry this on, carry the work on for ocular trauma management in your future career. So
Thank you so much,
tell us
sir.
something about your current practice, Ravija.
I'm currently working as assistant professor in the Regional Institute of Ophthalmology at Ahmedabad. And I've done my long-term fellowship in Orbital and Oculoplasty from Shankar Netralaya.
That's wonderful.
Last year, I'd taken a part in debate on firecracker injury, and you were the one who were judging the debate. You know, yes,
So I'm sure that you will be a wonderful advocate for us, and being at an institution, whatever you do has a real multiplier effect, because you will be able to educate a lot of people in this matter. So wish you a great future.
Dhananjay, yeah, you can speak, Dr. Shukla sir. Dhananjay, Rupesh here, yeah. Dr. Shukla sir, Dr. Grover sir is talking.
Yes, yes.
Dr. Shukla sir? Yeah.
Sir, please congratulate Dr. Ravija.
She's the runner-up.
Dr. Ravija, congratulations to you.
Thank you so much,
Dr.
sir.
Ravija.
Thank you so much, sir.
Ravija, you are lucky to
Good
get
luck to you
blessings from
in
the
future.
Godfather.
Yes, yes,
Stalwart.
indeed, I'm really blessed.
Founder members.
Good luck to you.
Thank you so much, sir.
Yeah, Ravija. So he is the patron of our Ocular Trauma Society of India, the first and the last word in the subject of ophthalmology, that is Dr. Shukla in our country as well as across the world. So you are really lucky and blessed to have his blessings. Congratulations once more, Dr. Ravija.
Thank you so much,
Hope to
sir.
see you again, continuing with your zeal and even in the field of ophthalmology trauma. So now it is time for us to go for the winner. So who are the winners in the section?
Dr. Shailaja Ketkar is here on the video.
Okay, Dr. Shailaja madam.
No, इसको यही बता दिया यहाँ से अनम्यूट नहीं किया बात अनम्यूट कर दिया हो गया
हेलो केतकर मैडम
तो अब इसे दोबारा आपको म्यूट करना है खुद को
हाँ
Madam, you have to unmute yourself.
इसे दबाना हो म्यूट
Hello.
Madam Ketkar madam, good evening. Dr.
Good evening all of you.
Thank you, madam. And you are a runner-up in the category of more than 40 years, and you
Yeah,
get
yeah.
a voucher of 10,000 rupees. Dr. Ashok Grover is going to interact and felicitate you.
Yeah.
Congratulations, Dr. Shailaja.
Thanks a lot, Dr. Grover. It's my pleasure.
Thanks for being a part of this quiz and for doing so well. We hope that you will continue to be a part of the ocular trauma family and keep educating everyone on the various aspects of ocular trauma.
Thanks a lot. Thanks a lot.
I'm really happy to share that she's a granny and she has the zeal. She is a granny of two grandchildren, I believe.
Three grandchildren, three.
Three grandchildren.
Update. This is the update.
Yeah, this is a great.
It's
Thank
really
you.
commendable. I think we should all salute her at her zeal to participate and learn and win the prizes. Winning is a different part of it, but yeah, she could make it and rub the shoulders with the younger generation. We salute you, ma'am. Congratulations.
Thank you.
Prashant, Dr. Gaurav Majumdar also has joined.
Okay, Gaurav. Okay.
Dr. Gaurav?
Gaurav? Yeah, Gaurav, are you there? Can you hear us?
Yeah, he's there. He's muted.
Dr. Natarajan sir was you are section 3 winner in the category of more than 40 years. Can you and join us?
Hello, Dr. Gaurav.
Sir, can you hear me?
Yes, we can hear you. Congratulations, Dr. Gaurav.
Yeah, fine, sir.
So, where are you working, Dr. Gaurav?
Yeah, sir, I'm actually doing private practice in Kolkata.
Okay.
So, I'm working as a general ophthalmologist and anterior segment surgeon.
And where in Kolkata you are practicing?
I'm practicing in South Calcutta. No, it's just clinics, various clinics in South Calcutta.
And do you see a lot of ocular trauma?
Yes, sir, depends. During the COVID times, yeah, I've got quite a few cases. Yeah.
Okay.
Different types of blunt trauma and penetrating trauma. Yeah, yes.
And do you like?
And I'm very keen. Sorry, sir.
Do you like to become Ocular Trauma Society member?
Yeah, I'm actually like, so there was a problem in the form. It's a issue is coming that the name has to be forwarded and seconded by OTSI members. That's a problem. So how do I get in touch with the OTSI?
You send your form, we'll be able to manage that.
Yeah, we will propose. Don't worry.
I will give you one name.
You send the money. You send the money and the form.
I am giving him one name. He can go for that. Dr. Abhijit Ghosh is member of OTSI. So you
Okay,
can
sir.
Okay, get it signed by him. Rest will do it.
So
Sure.
You send form and remit the money online. We'll do rest.
Yeah.
Okay. So the money is
after you. The whole executive of OTSI is there to recommend your name as a proposer and seconder. So become a member.
I will propose. Prashant, I will propose. No problem.
Thank you.
Thank you, sir. Thank you. So now we move ahead with the
Prashant,
last
sir.
part of it. Yeah.
Sir.
Hello? Not to go. Prashant, ask them not to go.
I attended the brain teasers last week, and I also got a prize in the section 3, sir.
Yes, I'm aware. I'm aware, Gaurav. So you stay back for us because the president has certain surprise packages for you at the end of it, up his sleeve.
Thank you.
So hold on for a while.
And only those people who stay, they will get that surprise package.
Yeah,
Those who are not there, they will not get.
That's right.
So the final winner of the session tonight was in the category less than 40 years, Dr. Muthu Krishnan from Chennai and Dr. Rupesh Agrawal, sir. You are supposed to felicitate him and interact with the guy.
Hello, Dr. Muthu Krishnan.
He is not there. He's not there, Rupesh. You can interact with me. I can collect the money.
Okay, congratulations, Muthu. We are missing you definitely. And
See, I am there from beginning to end. There, some price you have to give me.
Yeah, we give the prize to Natarajan because he'll give a matching grant. So the equal to that he will donate additionally.
So the last prize is for the winner in the category more than 40 years, and that is Dr. Tanika Chalam from Puducherry. Is she there?
No, he. Tanika Chalam is a male.
Okay. And Dr. Mukherjee, sir, our president, sir, is going to.
No, he is also not there. So both, I think, me and Dr. Mukherjee will take.
So we are at the conclusion of our winner felicitation ceremony. Now I hand over it to President OTSI Mukherjee, sir, who has certain surprises up his sleeves to be declared for winners. Sir, Mukherjee, sir.
First of all, I would like to congratulate Dr. Tanika Chalam for she has won she's winner of above 40 years. I could not get her here, but I have the surprise to tell you that whenever we are going to have the physical conference of OTSI, all the winners of this quiz competition, they will be our guests.
Wow.
So that is the added thing. They will be our guests.
Very good.
Please convey to all the members, Prashant,
Yes, sir.
And their name should be given to Dr. Mehul so that we can formulate for the future. This year, this year there is no physical conference, so next year most likely, if possible, we will have that physical conference.
So, sir, official letter can go from president and secretary to all the winners so that it is on record with a copy to the next whoever is going to be the organizing secretary.
Sure.
So winners, look at what you got. It's just not the prize money. It's just not sharing the dice with the who in ophthalmology. But today from our president, you get an opportunity to be a guest invited for a next Ocular Trauma Society of India, whatever that physical meet happens in the next year. So lucky, and I'm so envious of you people at such a young age. You will be the guest of Ocular Trauma Society, speaking on various subjects. Most welcome. Congratulations once more. Now I hand over to Dr. Mehul Shah, our Secretary OTSI, who will be announcing the prizes of our video competition. Over to you, Dr. Mehul, sir.
Yeah.
Actually, this is another venture for the younger generation. What Dr. Mehul has promoted, the video competition. This is all for the younger people, and all the original videos were analyzed. He is going to tell you in detail.
So I'm going to announce the.
You have to probably, you're having two instruments.
No.
Mehul, you have two instruments.
Announce the
better
result of the video competition. Total 53 video received by us, and it was exclusively evaluated by team. All people have worked very hard, and I think we took little longer, but ultimately we came with the conclusion that we have divided these videos into anterior segment and oculoplasty and posterior segment, so that we can evaluate in better manner. These are the winners of anterior segment and cornea and oculoplasty section. Dr. John Sarkar, Dr. Aditya Gorpade, Dr. Rashmi Krishnamurthy, Dr. Kirti B, Dr. Mahati, and Dr. Valda Gracia.
You know
These
where
are the winners for entry segment videos.
Mehul, do you know where are they from? The place from where they have come?
And these are the winners for posterior segment videos. We have 6 winners for entry segment and 6 winners for posterior segment.
Out of 53.
So Dr. Giriraj Vipute, Dr. Anshul Goel, Dr. Rohini Grover, Dr. Harshvardhan Gorpode, Dr. Hina Patel, Dr. Srishendu Monti. These are the winners for posterior segment. We will have an event. These 12 people will present their video on 8th of the November at 5 p.m. We have a next meeting, which is going to be on 8th of the November. These all will be able to present their video. So we invite all of you who are present here today to be part of this. These videos are very innovative and very interesting. Thank you.
Thank you, Mehul
With
Shah.
the permission of the President and Dr. Prashant, I have a pleasant duty. I want to thank all
And
the.
I hand over to Prashant for further proceedings.
I want to thank all the organizing team of the World Congress of Ocular Trauma with the guidance of President Dr. Mukherjee, for that we have concluded the process of accounting, and we are, in spite of all the organizational effort in a 5-star hotel, with difficulties of some people dropping out and there being very few donors for ocular trauma, we have managed to conclude the accounts and transfer the money yesterday to the Ocular Trauma Society of India account, which includes a profit of over rupees 3 lakhs besides the original amount that was due to them.
Great,
So
great.
it was the effort of all the team members who worked so hard with us to get the sponsors, to get the organizers, and the team worked very hard to bargain very hard with all those we had to pay money for, because we were never sure of being able to meet expenses and we were ready to spend from our pocket. But fortunately, because of the effort of all of you, there has been a saving of over 3 lakhs, which has been transferred to
So
Ocular.
I have a suggestion to Dr. Mukherjee. Permanently, Dr. A.K. Grover will be the organizing secretary. We'll get relaxed.
Sanjeev was the organizing secretary, and his effort is commendable. And the entire team, national as well as the local. Dr. Shalu Bageja is the treasurer. I thank all of them wholeheartedly.
But a great job.
Our treasurer, our
Ashok, really great job. I know how difficult it is.
3 cheers. 3 cheers for this team.
Yes.
Hip hip, hooray. Hip hip, hooray. Hip hip, hooray.
Thank you, Ashok.
And the comment from American delegate was, in US, we can only dream of holding a meeting of such scale on ocular trauma.
Yeah, exactly.
I must thank from the Ocular Trauma Society, Dr. Grover for the tremendous job that he has done. And also, I would like to thank Prashant here for doing this quiz competition for the younger generation.
Thank you, sir. So here we are at the conclusion of it. Thank you, everyone. Thank you, thank you to Ocular Trauma Society of India for giving me and entrusting me with responsibility. I'm sure I lived up to your expectations. And I'm thankful to all the guests, international guests, our own Indian guests, Dr. Rupesh in person. I would like to thank him profusely because it was his efforts that he arranged for the pearls from Dr. Peter, Dr. Prem, and all people. And he really was a backbone who was helping me out with all this. Also, I would take this opportunity to thank Akshay and Dr. Shilpi, who really worked hard for this quiz. I know how much efforts they have put in. My sincere thanks. I'm just the face of whatever efforts they have done. In fact, all credit goes to these two younger generations. And I'm really thankful. And once more, thank you.
Dr. Boparai has just joined.
Dr. Boparai wants to speak something.
Dr. Boparai is here. Sir, good evening.
Good evening, sir.
Good evening.
Good evening, sir.
Nice to see you, Dr. Boparai, sir. Sir, you have to unmute. You have to
unmute.
Dr. Boparai, you have to unmute.
Unmute, sir.
No, you have to unmute, sir. Dr. Boparai, sir.
Can you tell the administrator?
No, Dr. Boparai, sir, you have to unmute.
Sai, can you unmute him?
It's so nice of him. It's such a thorough gentleman. He gave me the first consent of all of the executives. He was the first to give me consent. Prashant, I would be there for your program.
Yeah.
Really admire his patience, persistence and his zeal at this age.
Sir, you have to unmute, sir. Dr. Boparai, sir. There's a button near the mute.
We want to hear unmute.
You have to go down to the button.
Sir, left down. Yeah.
Yes.
Yes, sir. You can. No, still not.
Again.
Just again. Just press once. So you have to unmute.
There is a
Just
microphone. There will be a microphone button with red color and strike, sir.
Just press it once.
Microphone button next to the video.
Yeah.
Yes, sir. We can hear you. Yes,
Hello.
sir.
Hello. Hello.
We can hear you, sir.
Yes, sir. We can hear you.
Hello.
Please speak, sir.
Can you hear me?
Yes,
Yes,
sir.
sir.
Yes.
Yes, sir. Yes, sir.
Well, I will say it has been an excellent show. Excellent show. Credit to Nettie, you, to Shop, to Guru and GC, Mehul, and everybody. And particular thanks to Rupesh for being over there. Well, excellent show and keep it up. I'm proud of all of you.
Thank you.
Thank you very much.
Thank you, sir. Prashant.
Thank you, Prashant. Prashant, wonderful show.
Thank you, Prashant.
You are muted. Prashant, you are muted.
Thank you, sir. Once more, every one of you. In fact, my heartfelt thanks to Dr. the first person to give us a consent for this program, and he accepted to be with us live during the program. I'm indeed indebted to Dr. Shukla sir, Major Boparai sir, and all the president, secretary, and vice presidents, and all the executives of OTSI. Thank you once more. Let's call it a day. Let's call it a day. Thank you.
Well done, Sean. Very well done, sir.
Yes, sir. Thank you, sir. Thank you.
Thank you all.
Thank you, sir.
Thank you, Dr. Mukherjee, sir.
Thank you, Nati. I'll talk to you.
Yes.
Thank you, sir.
I'll talk to you.
Okay, okay, sir. Okay.